We put on these heart-to-heart education events because it is part of fulfilling our mission here in the cardiovascular team. So our mission is to take care of the hearts of our community so that people live happier and healthier lives. Isn't that a wonderful mission? So that's what we try to put together our services that we live that out. So one of the ways that we do that is, how many of you in the room have taken the Cooking with Heart classes? I know I have several. Oh, there we go. Oh, I see. Yes. So Cooking with Heart classes are something we put on in Rock Island at the culinary nutrition kitchen there. And they're 4 weeks of fun getting together, exploring recipes, learning new concepts with nutrition. If you do the in-person, you get to taste. We do have a virtual option, so they're free to the community, and we have coming up, we actually have the August classes full, both virtual and in person. We have September, we have Cooking with Heart for Cancer, held on Tuesdays at noon, and we have October, we're both running the Cooking with Heart Foundational, which is for anybody transitioning to healthier eating, wanting ideas on fun things to make that are delicious. And then in October, we also have the Cooking with Heart for Diabetes. Those happen in the evening, so if you're interested, grab, you actually have in your bag a brochure about those. So to contact us, we have email there, and we have our phone number. And if you're on our email list, we do send out once a month a heart health newsletter. And this last one we talked about is heart disease reversible. So there's a lot of interesting articles there about how to keep yourself healthy. So if you're not on the newsletter, not getting that, not our email list, just check with Tanya there in the back of the room and she'll get your email, make sure you get on it. So Dr. Singh, well, we're excited to have him here sharing about a very important topic. And he received his medical education at Pashila Government Medical College in India. He completed his internal medicine residency, cardiovascular disease fellowship, and interventional cardiology fellowship at Chicago Medical School. During his training, he also served as chief resident and chief cardiology fellow and was elected to the prestigious Medical Honor Society, Alpha Omega Alpha. Dr. Singh has published numerous peer-reviewed manuscripts and abstracts and presented at various national and international meetings. He was awarded Young Investigator Award by AACIO in 2010. He joined Cardiovascular Medicine in July 2015. He's board-certified cardiovascular disease, interventional cardiology, echocardiography, and nuclear cardiology. Please help me welcome Dr. Singh.
That was a lot, but a long time ago. Anyways, so today we're going to talk about one of my favorite topics I'm very passionate about, which is heart disease in women. And I have researched on this topic a lot, read about this topic a lot, and over the years I've found out that even though heart disease continues to be a genders, its impact on women's health in this day and age is huge and way undermined by the patients and the healthcare providers equally. So this is a huge topic, which and probably requires 3 or 4 of these sessions where we can talk about how the risk factors impact women differently, how their symptoms are different, how the diagnostic runs differently, and how the prognosis is different. Today we are going to talk about mostly the risk factors, how the heart disease is a little different in occurrence in women, and their symptoms, most common presentation symptoms. At any point of time, if you have a question, you can raise your hand. Otherwise, we can do a brief Q&A at the end of the session. I came to Quad Cities in 2015, joined Cardiovascular Medicine, which is the local cardiology group. We cover both Illinois, Iowa, both sides of the river. It's been a wonderful transition. I am blessed with wonderful kids who were 3 years old when I moved there and now are 11 and asking me questions they should laugh. So I'm glad to be there. So I forgot to include a slide here where we still talk about the burden of cardiology or cardiovascular disease in women in US. It continues to be the leading cause of death, way more than all causes of cancer or all types of cancer combined. It still continues to be the major cause of sickness, major cause of what we call as morbidity, which is loss of man hours. Patients are admitted to the hospital, patients are out of their jobs, and obviously their social lives. And despite that, and when you compare the awareness about cardiovascular disease in women to, I'm just going to throw this out, breast cancer in women. The initiatives we have for the awareness of for breast cancer are exponentially high as opposed to what people think about cardiovascular disease in women. And as I've said, and I'll probably continue to say it a couple of times, it is two ways. It is both the healthcare providers and the patients. The patients don't realize that how cardiac disease can happen in younger females, females after menopause, and so on and so forth, and as well as the healthcare providers who, there was a myth when I was in medical school that heart disease is basically a disease of men, mostly Caucasian men, there is enough data out there which continues to tell us that that is not the case. It is just a myth. Heart disease is still a big burden on everybody. So, as I said, today we're going to talk about the cardiovascular risk factors. We divide risk factors into modifiable and non-modifiable risk factors. If you're born with, a big family history of heart disease, we call it family history of premature heart disease, where if you have a first-degree male relative who has a cardiovascular event, whether it's a big heart attack or a stroke, less than 45 years of age, or a first-degree female relative less than 55 years of age, then genetics are not on your side. That itself is a big risk factor. The sad part about that is you cannot change it. You cannot change the family and the genes you are born in. You're born with that. Obviously, the other non-modifiable risk factor is age. The heart disease continues to happen and thrive in the 5th, 6th, 7th, 8th decades of life. We are seeing the advent and onset of heart disease now in the earlier decades, even in the 40s and 50s, partly because of increased awareness, but partly because of our unhealthy diets and all that contributing as well. But in any case, you can't change age. So we are going to spend most of our time in those modifiable risk factors where we can do something about it and decrease our chances, or at least our the fact that we are going to be having significant cardiovascular event. Keep in mind that it's not that healthy people don't have heart attacks. Otherwise, an athlete or somebody who runs marathons will never have heart disease. They also do have cardiac events. So it is a combination of a lot of things. Science has understood most of them, but there are still many things which we can't explain. How somebody who has a cholesterol of 100 and an LDL of 50 still ends up having a heart attack. We have no answer to that. But if you extrapolate data from populations of hundreds of thousands of people, we know that there are certain things which predispose you to having those events. And we're going to talk about how they affect primarily women. So the most common ones, and this is going to be out of order from the table, but the most commonly modifiable risk factor is sedentary lifestyle. And somehow we have become attuned to that, and we have accepted it as our lifestyle to not do a lot during our week, during our working life, and it's okay with us. So 40% of women report no leisure time of physical activity. And it hurts me to say that women put everybody's health on top of their health. Their kids, their husbands, the dogs, the neighbors, the distant cousin, and then it comes to their health. And I have heard this not once, not twice. I hear it almost on a monthly basis as well. That I gained weight because I was taking care of my ailing mom or ailing dad, or and again, this is such a complex situation that in those 5 minutes which I have with the patient, I cannot understand the whole complexity of it. But my advice only is that don't overlook your own health. It is equally, if not more important than somebody else. So, and clearly there is data, I showed you a graph where women as compared to men in every race aspect, whether it is Caucasians, Hispanics, African Americans, they do less physical activity. And really there is no explanation to it. It is not that there is one fixed real estate everybody from the biggest CEO in this country to me and my daughter have, which is fixed, is the 24 hours in a day. So everybody has to make time. So we have to really make an effort to do meaningful physical activity in a day back. Obviously, the lowest prevalence, there is some data which obviously correlates socioeconomic status with physical activity. And then there is even lower prevalence of leisure time in African American, Hispanic women as compared to Caucasian. So this is the study was done, epidemiological study, which said that when you see a percentage of populations, as you can see, when compared to their counterpart, men in every race, women do less. And then this is a good graph which answers a very important question I encountered. Well, I just walked, and I don't think if it helps, or I don't know if walking in a driveway helps at all. So you can see that for every hour of per week you do some physical activity, there's a linear decrease in your age-adjusted relative risk, which means your risk continues to go down. And then the green and blue bars show that both walking and any other kind of physical activity, whether it is going up and down the stairs of your own house in winters, or walking in a mall, or water aerobics, or any other physical activity, as long as you stay active, it decreases the risk in the same proportion. There are minor differences, but you can't really tell them apart. So any physical activity, whatever, I know we have to keep safe. Arthritis is a big problem in 6, 7, 8 decades of life, but as long as you can stay active, you can find a way, whether it is a stationary bike, water aerobics, whatever you can do, it is going to help. So these are my take-home messages here, that saying no to physical inactivity. You have to actively and consciously say no. A little activity goes a long way. We have seen that in the previous graph, but in the previous slide, even if it is walking 200 yards, 100 yards, and I have people who have not been active a lot in the previous years due to anything, and COVID played a big role in that. And they're like, I can't do much. Well, you have to start somewhere, and the idea is to start with as little as maybe even 5 minutes, 3 minutes. You do it twice a day, you continue to do it on a daily basis, and eventually in 3 months, 6 months, you're going to increase your returns. It's the bottom. That's how it happens. So a little activity goes a long way. Don't get excited. Start slow. As I said, don't run yourself into a wall. When it happens in me as well, I'm going to run 8 miles today after 4 weeks or 8 weeks. You can't run 8 miles, and eventually you're going to be like, I can't run. You have to start with a moderate. So same thing, you have to start slow, build your endurance, build your tolerance, make opportunities. Park at the farthest spot in ID or Walmart. If there is only a flight of stairs or 2 flights of stairs at work, take those flights. Make opportunities when you have to walk. I know in Midwest, we are blessed with our winters, so you have to go to the mall, you have to go to Costco, Hy-Vee, whatever works for you, but make opportunities to stay active. And be safe. That is also very important. The last thing we want is somebody slipping on ice or, we don't want that. So you have to make sure you have a partner if needed, you have a safe environment, you have appropriate shoes, right amount of daylight. I know these things appear very common sense, and you might be thinking, why is he talking about it? But I have people who say, oh, well, doc, I fell because I think my shoes were bad. So those things do matter. If you are not very confident, have a walking pal. That helps. All right, so that's physical activity. So then the second biggest one is smoking. I have to say, and I was with my family for the first time to Italy this spring break, and even my kids know this. I think US has done remarkably better in smoking cessation in the first world or developed countries as opposed to any other country. I think we have done a remarkable job. The awareness is amazing, and many people now, as opposed to 70 years ago when people took on smoking due to peer pressure, now they're giving up smoking due to peer pressure, which is amazing. And having said that, the data is very phenomenal. That is the relative risk, and you can see if somebody has smoked 20 cigarettes per day, for somebody who has not smoked, their risk is almost 5.5 times in the same person of having a cardiovascular event. That's very, very big data. So the number of cigarettes do matter. So I tell everybody there is enough evidence which says that it takes about 7 attempts for a chronic smoker to quit successfully. 7 attempts. So don't quitting. Unfortunately, we are so busy in our cardiology practice that I typically do not prescribe, the Wellbutrins and the Chantix because people have to follow up closely for some side effects. So we encourage you to talk to your primary care doctors and find out avenues, but don't quit quitting. It is important, and you will feel remarkably better. The benefits are the same in both men and women. Obviously, the heart disease or the impact on the inner lining of the arteries, whether it is the carotid arteries, the coronary arteries, or the brain arteries, that starts to reverse very soon. And it reverses to almost normal in about 3 to 5 years, as far as the arterial health is concerned. What smoking does is smoking has a lot of free radicals and antioxidants, oxidants, which inflame the inner siding of the inner lining of the arteries. It is very similar to when you have common cold or flu and the inner lining of your nose or throat is inflamed. It is red, it is angry, it is tribal. And when that happens in the inside of your arteries, you can have blood clots and all that. So that is how it leads to vascular events. So the benefits are same in both genders, but where women, they face different barriers. There is I hear this almost on a daily basis about weight gain, almost on a daily basis. And it is possible. It is possible because, and I by no means I am encouraging smoking, but cigarette smoking decreases grade. And when people quit smoking, they eat. And when you eat, you gain weight. So we see this
Gaining 10 pounds is bad, but it's not as bad as smoking 10 cigarettes. So I still encourage anyone, if any one of you still smokes or your loved one smokes, to tell them that this is a barrier you have to get across. It requires a lot of willpower and you have to do it. Obviously, that particular aspect comes with, at times, concomitant depression in younger females. And that is also which we have to deal with. We defer this to primary care doctors, but it is also a very undermined clinical issue, which is mood disorder based on weight. It's a true problem. It has to be recognized for us to adequately address and treat it. And this day and age, the physician offices are so busy, sometimes we don't even have time to talk about so-called trivial issues, but these are not trivial. They have a true burden on society. So, a few take-home points for cigarette smoking: leading cause of preventable death and disease in the US. What you can prevent. It is the best intervention ever. I practice cardiology with the right medications, do stent procedures, replace valves for a living. If you smoke and you quit smoking, you are probably increasing your lifespan. You're adding most days to your life more than what I will do for you. That is why I said this is the best intervention ever. Not only from heart standpoint, from your lifestyle standpoint, you'll never develop bad lung disease and all that. Risk of heart disease starts decreasing within 24 hours and decreases significantly within 1 year, almost back to a non-smoker's range in about 3 to 5 years. As I said, 2.5 to 3 years. And then this is important. A lot of my people say my smell and taste improve. My friends want to be my grandkids hug me now. They used to say you smell. Those are issues which I've learned as I've practiced more and more, that these are the things which bother me. All right, another third one is the obesity epidemic we have. And this is a legitimate health problem. This is the burden we have in our society. And as with everything else, the first step is to accept it. So as compared to 50 or 60 years ago, an average American is 25 pounds heavy. That's a lot, 25 pounds. If you translate it into gallons of milk, the milk cartons, imagine how many milk cartons an average American is carrying in their bag every day. This is a chart, it's slightly older, but this AHA has this chart on their website. This is the proportion of population which has a BMI of more than 35, which tells us that you are obese. You can see in 1990s, maybe 10 to 15%, which went to about 20% in 2000s, and now we have states where more than 30% of the population is obese. And I'm sure this trend is on the rise. There is no way this is something else. So this is also a true healthcare problem we have. And it is not only from just cardiac standpoint, from general gut health, inflammatory markers, your more knee replacement surgeries, hip replacement surgeries, back problems, everything, the entire spectrum exponentially has gone up. You can see that this is a chart for women. Amongst women, there is, as the BMI goes up, you can see that the relative risk continues to go up. There is a linear trend, and this is very clear. There are a lot of people who suffer from metabolic syndrome, or what we call as syndrome X, and I'm going to talk about those two as well. where everything is almost borderline, but that itself is a risk factor. So we can talk about that. This is an interesting slide. I saw that when the youth is on your side, and you have a certain weight at the age of 18, if you have gained about more than 20 kgs, which turns out about 44 pounds or 45 pounds since that weight, your relative risk is about 7 times as opposed to if you have gained about 15 kgs. So mid-age weight gain does matter. And the reason why it matters is because it's not muscle mass which you gain, it's mostly obesity, it's mostly through fat and truncal fat. When you are well built during your teenage years, you work out, even if your BMI is higher, there's a lot of muscle mass in there, which doesn't necessarily translate into a risk factor. So again, the obesity and physical activity go hand in hand. You know, that's goes without saying. Diabetes, again, this is a disease, it's a true disease, so I'm not going to spend more time in it because this is modifiable. Obviously, the first physical activity and weight. Sorry, my allergies are acting up, so. But the management of diabetes is obviously goes with the help of your primary care physician, the cardiologist, the endocrinologist, but it is one of the biggest risk factors. 65% of diabetics die of cardiovascular disease. And their heart disease, the relative risk is about 2 to 4% given the other comorbidities, if you have high blood pressure, cholesterol, kidney disease, history of stroke. So diabetes is a big burden. In my professional life, I finished my residency in 2009. There were not many drugs. We had metformin, we had a couple of older ones, and we had insulin. But now in the last 10, 15 years, so many good drugs have come, so many good drugs. I've actually taken successfully my mom off insulin with the Januvias and the Ozempics and all of that. So controlling diabetes has become easier for us. You can see the linear correlation between mortality rates as you have uncontrolled diabetes. The more number of years under your belt correlates linearly with that you're going to die from a cardiovascular cause. And obviously, diabetes is big in non-Caucasian populations, extremely big. And the HbA1c's tend to be very higher because of the metabolism. So this is what I was referring to, metabolic syndrome, where you can have a lot of combination of just the fact that you have a tendency to have poor metabolism. You can have 35 inches, this is in women, men have different criteria, but 35 inches of waist circumference, triglycerides are greater than 160, HDL is a little low, blood pressure is borderline high, glucose is borderline high. But then this syndrome, or we call it syndrome X, itself has a cardiovascular risk propensity. So tying all of this is into the lifestyle modification, the diet, the physical activity. All this is just one big spectrum. When you look at it from any side, it's eventually going to come into the fact that we as patients and individuals have to take control of our own health. Another one is hypertension. Obviously, you know, a lot of people in the US have hypertension. It's more prevalent as we age. One of the reasons is our arteries continue to get calcified, and when we have calcified arteries, you tend to have less compliance and more stiff arteries, which lead to higher blood pressures. Obviously, it correlates directly with mortality as well as risk of stroke and kidney problems. And for every 20 or 10 millimeter reduction or increase in blood pressure, you can cut your risk into half or double it. The risk of heart disease and stroke. So this is important to take care of. We have seen many times, and I am a part of this too, that I was studying, or that I was diagnosed with high blood pressure when I was 18. I was I had put a lot of weight at some point of time. I lost a lot of weight. I came off all my medications. So if you maintain your ideal body weight, you will come off medications, and it helps. There is certain diet plans. It's called DASH, diet or targeting to stop hypertension, something like that, which tells you that you have to have more colored vegetables and leafy vegetables in your diet as opposed to wide and all that. I also like them, but every now and then you can take it. Sodium restriction to 3,300 milligrams per deciliter. This is AHA recommendation. The problem is this does not tell us how much salt. So what I tell my patients is there should be no salt shaker in the house. As it is, our food on the shelf has so much salt in it, which is used as a preservative, that nobody should be adding more salt. For the food which we cook, a pinch of salt per meal is all you need. You can add black pepper, you can add red chili powder, or whatever you want for taste, but salt should be controlled. And then obviously decreasing alcohol, decreasing caffeine, all those things help increase physical activity. Cholesterol and diabetes. So for everyone, I encourage a lot to get your annual labs. Most insurances in the US cover it. It is just, the labs are so old these days that you have to go there and wait for a certain time, but you have to get your annual fasting labs. Everybody should know their numbers to at least a certain degree, at least a ballpark range. My cholesterol is 200 versus 500. My triglycerides are 150 versus 800. You should know to a certain degree so that if you know those numbers, go to a friend's house, you're offered something unhealthy, those numbers might make an impact. If you don't know it, if you've never tested your numbers, you're not going to face the reality anytime. Again, as I said, these are ballpark numbers. You can get it online, you can get it from anywhere, but have an idea about how good your control is. The only thing worse, and I tell this in verbatim language to a lot of patients, is the only thing worse than finding out that you have one of these labs at normal is not finding out that you have it. The reason is all these things we have mentioned, high blood pressure, diabetes, bad cholesterol, they are silent killers. If you jam your hand in your car door today while going out, I can assure you that is not going to kill you. It's not life-threatening. But you will go to the ER, you will go to OR urgent care because you are in pain. That pain drives you here. This is exactly the opposite. It doesn't cause anything, no symptoms. So we don't check it, we ignore it, but they continue to affect your health way more adversely than that pinky fracture. So it is very important to manage these numbers. For women specifically, there are 2 or 3 things. One, estrogen is cardioprotective. So this has been proven that before menopause, the true thrombotic heart attack, where you have a big blood clot in one of your heart arteries or a big blood clot in one of your brain arteries, we call the stroke, does not happen a lot in premenopausal women. Once after postmenopause, the risk is almost the same as men. Number one. Number two, HDL is more important in women than men. So not that good cholesterol should be ignored in men, but in women, if you have good cholesterol, it really balances out your bad cholesterol. And really, there's no explanation of it that is how the metabolism is. So if you can bump up your HDL by half a glass of wine or physical activity or whatever it is going to be really beneficial for your vascular health. The other ratio, which is very important, and you will, whenever you get your labs, these days the labs mention it, is the total cholesterol versus HDL ratio. And if it is less than 4, it is very good. Yeah. So again, balanced diet. Everybody asks me what diet should I eat, and there are many kinds of diet out there. The internet is full of them. My only two suggestions are: one, make changes which are sustainable. Don't make a change which you're going to follow for a week, 10 days, 15 days, 2 months. Let's say afterwards. And for women, a lot of it comes down to cooking, believe it or not, because they are the ones who can cook not only for themselves, but for a lot of other people in the household. So if they can find time to cook for a healthy diet, so be it. Otherwise, you have to make time to eat healthy, balanced diet, which you can sustain, whether it is relying on your, local IV or having somebody in house with a chicken breast for you or something like that, but you have to make certain sustainable changes. Obviously, vegetables, fruits, this is all common sense, having a balanced diet. I don't necessarily promote any diet. Trinity has a very good, program, the Pritikin veggie-based diet. I've taken their cookbook home myself. I try every now and then a dish from that cookbook, but we have a lot of patients who, after a cardiac event, have benefited from those kind of community programs. So this is just a slide. I mean, you don't have to we don't have to spend a lot of time in it, but this tells you that correcting your numbers by lifestyle modification is possible. Every time you don't have to, I know there is a lot of, statins have become the #1 prescribed medication in the US after some anti-psych medicines or for mood. And the healthcare providers push statins a lot, but you can achieve a lot by, if you're with saturated fat, you can have an 8 to 10% reduction in LDL. Weight will cost 8%, and adding, fiber is going to decrease it by 5%. So you can actually decrease your LDL number 25% just based on lifestyle modification. That's a lot. So this is one slide which tells you that although all the risk factors are important, what is more important for women? And if you can take one message from this talk today home is the combination of the 3 major risk factors on the right side of the slide. Diabetes, obesity, smoking. They have, as opposed to men, they affected women way more drastically. So control your diabetes, quit smoking, physical activity, all those are going to help you a long way. Then these are some newer things. We don't necessarily test them routinely in our clinics. High sensitivity CRP is one of them. Fibrinogen. And the higher the levels, we have seen that there is more chances of having heart problems. CRP is just necessarily an inflammatory marker. It tells you that there is more inflammation in the body. High sensitivity can predict a cardiovascular event. There have been studies which tell us if you have a high sensitivity CRP and you start you on right medications, is it going to have clinical or is it going to translate into clinical benefit of preventing a heart attack? Those studies have been negative. And hence, this never became a routine test. But the laboratory data suggests that the higher the CRP, the higher the fibrinogen, the more number of events specifically in the brain. It's good to know. This was a study done in Stockholm, which emphasized mental stress on the heart health of women. And if somebody who is married and has marital stress, which is extremely difficult to quantify, there is no way you can define, well, my stress is more than yours because of this, and this reason. And this was purely a yes and no epidemiological study where they said, do you have stress in your marriage or not? And the people who answered yes, they were found to have 3-fold increase of Parkinson's. So I don't know what to do with this data. What to do with this data helped me. And again, this is also very important and somehow it affects our women population way more than men, is that depression is number one, not very adequately treated in women. And I have no explanation of this. I don't know whether it is the lack of access of providers or whether it is the social support needed or whether it is the lack of initiative by the patient themselves. I don't know, but I have had many patients who have come to me and in the 3 or 5 minutes they spend with us, they say, "Now I think I need help. I'm not feeling good, but I have no way to go anywhere and talk to anybody." So, but when you extrapolate it, this does affect your heart health. So if you're able to recognize this at a certain stage in life and treat it adequately, it's going to help. Then we're going to have a couple of slides, actually just one slide based on the atypical symptoms for women. So when men complain of acute coronary syndrome, or what we call as heart attack, it is a huge spectrum of it. It happens due to a blood clot in the heart arteries. The most common data shows about 75% of the men would say, and all these studies mostly have 80 to 90% Caucasian population. So we are a little biased towards Caucasian in the studies. But the men would say that I have an elephant sitting on my chest, or it is chest pressure, or somebody is squeezing my heart from within. When you look at those studies and look at the women subpopulation, on the micro level, the pathology is a little different. Instead of a thrombosis or a blood clot, there is a rupture. And that rupture is very slow in progress. So the first thing is women's symptoms. They start very slow and it's an insidious process. It's a slow, gradual kind of a process which can last for 2, 3, 4 days, as opposed to men, they have a heart attack sitting on a bar. They're like, that, when you call 911, there is a, as you see, one tunnel on my chest. Women sometimes have small ring symptoms, right? You know, I'm just not feeling well, I'm very uncomfortable. And then the symptoms could be a lot different. It could be sharp chest pains, it could be shortness of breath, it could be just feeling of cramping, diaphoresis, I'm out of energy, I can't walk. As your fluid tank is empty, you have dizziness, and you're nauseous, vomiting. Any of these symptoms can actually be symptoms of heart attack in women. And that is because of the fact that because of the plaque rupture, there is not complete occlusion of the artery most of the times. So there's a trickle of blood flow going, which can give you a variety of symptoms. When the blood flow is abruptly cut off, mostly in men due to that clot formation, you have like phenomenal chest pain. People come with shock and low blood pressure. So you have to recognize those symptoms. If you have symptoms, not necessarily that every time you have nausea, you should call 911, but if those symptoms are persistent and are not going anywhere, don't ignore them. I've heard every one of them. I've heard acid reflux, I've heard migraines, and I've heard the bad word migraines. And these are all heart attacks in women, so recognize those. Obviously, if you do have these kind of events, you come to the ER, one of us will take you and will try to restore the blood flow to your heart muscle. And then what there are? Many patients ask me, well, what are you looking at? First of all, don't get disheartened. People who have heart attacks, they lead absolutely normal life. They can run marathons, they can attend weddings and all that. So it is a disease which can be easily corrected. Obviously, we have to continue the things which we have emphasized on, continue a healthy lifestyle. Follow up with your cardiologist regularly. Once you have heart disease, whether it is plaque rupture, stent, congestive heart failure, AFib, you have to establish yourself as a heart doctor, even if you are at a once a year club. It is important that we see certain things on you on a yearly basis for us to prevent a reach to the hospital. This is the biggest thing. Again, in this day and age, putting a stent and alleviating your symptoms is very easy. Some people want to go home the same day because they feel like $1 million. It is a big deal for the body, and that can happen again. So medications are going to be your friends lifelong. So you have to take complying with your follow-up appointments, complying with your medications. As I said, utilize the available programs in the community. The critical diet, the rehab programs, YMCA, all those things where we live a wonderful world.
Wow. So lots of things to circulate, to pay attention to as women. So to take care of ourselves, thank you for being here. So you are your best advocate. So just like Dr. Singh said, it's important that you take care of yourself and you speak up. I know you've got lots on your plate, a lot of people depend on you, but you have to take care of yourself. So watch in the email for our August heart to heart education. We're still finalizing details, so watch for that. And we want to give away, we have a t-shirt and we have our basket here. So Dr. Singh, if you can do the honors. And the first one for the basket is
566799.
And who is this? Lisa. Lisa. Congratulations, Lisa. Awesome. Okay, and the second one is
566797.
wonderful. Okay, so you get to pick a t-shirt. We have a couple different to choose from. And what is this young lady's first name? So, well, there's we have a t-shirt for you too. So, yes, awesome. Well, thank you everyone for coming out. Grab a water, make sure you keep hydrated in this hot weather, and you have a wonderful evening. Thank you.